Uh, Today I'll give a presentation about mediastinum radiotherapy in female patients. Outlines of the presentation will be position of CT simulation of female patients. Second point will be breath hold techniques. Third point will be some tricks in contouring mediastinum. The fourth will be arc therapy fields needed in treatment of the mediastinum in females. And lastly will be tolerances of organ at risk of lymphoma cases. Please remember this photo. This is the idea of our topic today, the inclined position of the female patient to decrease the exposure of the breast glandular tissue if you will treat previously. And you can put the patient arms beside on back lock, the inclined a little bit 10 or 15 degree, just to have flat chest. Head can be immobilized and fixed by cast, the knee and ankle support. And this is adapted from the Emily Anderson Center from Bethany Dabaj and her colleagues in 2014. This is the geometric advantage of butterfly technique for treatment of mediastinal female patient Hodgkin lymphoma. And this is the short idea of the technique, inclined position, use beside using breath hold technique. They were using IMRT like two anterior and two posterior, but we can use two half arc anterior and two half arc posterior instead. And they achieve less tolerance for the breast and also for the heart dose. And the idea of this position, if you notice in the PET-CT initial for the patient with arms above, you can find in the same level glandular breast tissue appears in the exit of the field or entrance of the field. So here, again, for the CT simulation of the patient, if the arm is above the same problem is the same level, glandular breast tissue. But for the arms down, you may find less glandular breast tissue in the field. So it will decrease the exposure of the breast for the radiation and decrease the second malignancy. And this is the shape of the butterfly. If you notice this one is like a butterfly. The eyes those color wash, and this is difference between the arc therapy and also the ABB. So we treated some patients with the same technique, even some of them solid tumors away from the lymphoma, but we used the same with one patient side normal, B3, treated with surgery. And we did the same position just to decrease the exposure of the breast, and also the same here for one patient, upper thoracic mass, non-Hodgkin lymphoma, and we treated the same to decrease the exit dose of the radiation up in the breast. So with using modern radiation therapy for contouring and target delineation, and this is from International Lymphoma ILRG Radiation Oncology Group, and this is famous group in lymphoma, and I'm advising you to look for their guidelines. They did a guideline for contouring mediastinum. We were actually, they are advising for using involved site radiotherapy for all cases, no elective node for sure. But like before, we were treated all the levels of mediastinum. So just follow the pre-chemotherapy up and down. You can put to margin 1.5 centimeter to get the involved site radiotherapy. The width of the field, we were before saying that post-chemotherapy. Yes, you can use post-chemotherapy for the width, but again, respecting the area adjusting or adjusting or like in contiguous with the lung and also in contiguous with the chest wall and sternum. So because for with the recent modality of radiotherapy with IMRT and VMAT, you can achieve this target with less toxicity to the lung dose. So, and again, don't forget to use the breath hold technique for the superior mediastinum. And don't to confuse between 4DCT and the breath hold. The 4DCT will not help in this one, and just it will give you the exact margin to give the radiotherapy, but breath hold will help to displace the heart down, so it allows you to put a margin for your volume with decrease a lot for the heart doses. And also it can help for the superior, like gas or upper gastric and also upper GI tumor. It will help to decrease, or upper gastric tumor, it will help to decrease the margin needed. And also for daily variation, you can use for here fasting stomach for this one to decrease the daily size variation. And also you can displace the heart with breath hold and decrease the margin needed, because with breath hold, less margin will be affected for the patient. So please, first chance is best chance for the patient, so better to get ideally, and even you can send the patient for some centers if you don't have these facilities, just to decrease the heart dose and decrease the toxicity for the patient. We have organ at risk different here for the hematological malignancy. And again, for the international lymphoma radiation oncology group, they have their separate or their own guidelines for the, like for heart, for example, mean heart dose is less than 5 gray if you will treat by mediastinum. For you can accept 5 to 10 if you have bulky or necessary, you can accept more, but they put some optimal and acceptable and necessary guidelines, and less than the toxicity for the other solid tumors. For the UK, they added one organ, spleen, and I'm recommending this one also because it's achievable, and for sure the organ will be controlled, would control can be spared. So better to control it in the mediastinum and abdominal, and you can achieve if less than 10 gray mean dose, you can spare the patients from the mortality infection related to the infections. And if more than 10 gray, you can advise the patient to go for the infection vaccination, or to send the patient for infection control to have vaccination for this splenectomy 2 weeks before the radiation. And again, you're supposed to have updated guidelines, because we can spare the radiation completely for some patients and avoiding the toxicity. Here for the for the NSCN and Hodgkin lymphoma, adult patients, even stage 1 and 2 with bulky disease, we have two options: either to do combined modality, ABVD 2 cycles plus involved cycle therapy, 30 gray, ABVD 4 cycles, if you have Dovili PET CT after 2 cycles, 1 to 3. And you can like have the, according to Rafael study, AVD only for 4 cycles. After 2 cycles, ABVD. If the PET CT negative, you can add more AVD with omission of the bilirubin, and no need for radiation for this one. Again, for stage 3 and 4, you can follow the Rathel protocol only if the patient had, after 2 cycles, ABVD negative, even if it is initial bulky disease, you can just do extra 4 cycles ABD with omission of polymycin, and they give and no radiotherapy as per Rathel protocol. So this can help you to omit some patients from radiotherapy not needed. This also the confirmed by the RCR guidelines, and also I'm suggesting the site to follow the vaccination, and it is beside NCCN to confirm your knowledge. So in advanced Hodgkin, we have 2 studies. Telling group did randomized studies between radiotherapy versus no radiotherapy in advanced bulky Hodgkin lymphoma, and they found no statistical difference between those. But don't forget, if you will use combined modality, again, that the chemotherapy itself, 1 cycle can do 5 gray for the mean high dose radiation. So better to use like multimodality decision, and tailoring the plan for the patient according to the situation and according to the patient age and for sure performance. In conclusion, we are saying that young females are in need for special handling in treatment of mediastinum. Do CT simulation with contrast because this is the therapeutic chance for the patient, and you can do in two positions and compare, and you can choose the ideal one with less toxicity. Organ at risk for lymphoma are less than solid tumors, so put different constraints for your physics. Always think about breath hold techniques in treatment of superior mediastinum or upper GI to decrease the toxicity. Finally, review the updates of the guidelines and do peer review for all cases. Hopefully to see you all in person next year in Egypt, and thank you.